Shep, we're back with another episode.
We are. We love this episode. This is a great episode. This is something that's probably very close to the pair of us, very close to our research that we've done over the years. Tell me about it. What are we talking about?
CPR-Induced Consciousness.
Otherwise known as?
CPRIC.
Fantastic. Where did CPRIC come
from? A term
from?
which is everywhere, but where did it come from? I think you came up with that term, didn't you?
Well, I don't know whether I produced it or you. I think you did it. But anyway, it started, or we started looking into it when we went to that conference in Canberra, I think it was. And we'd had a couple of little drinks that evening, and you said to me what was the craziest thing that I'd seen, and we spoke about a patient that I've recently done that was waking up during cardiac arrest. And we're talking probably 15 years ago now. I think this was when we were first talking about it. And you said, no way, that's not real, that can't be real. And then the next morning you came to me with a proposal because you'd been and doing some searching about it, and it's blossomed since there.
Yes, yeah. You were, of course, well ahead of time as always, and were saying, how are we going to manage these people that wake up during cardiac arrest and CPR? I didn't even understand the question really at the time. I thought, if they wake up, they must have some level of ROSC and a perfusing rhythm, but of course not. They're in a non-perfusing rhythm, but you're doing such good compressions and ventilations, and they get cerebral perfusion and therefore wake up and can produce some challenges, can't they? So we did a systematic review.
Yep.
Before we jump to how to manage this, you got to go back 10 steps and say, is there anything out there? So we did a systematic review, and what did we find?
Well, we didn't find much. No. So I think, was it 2015? I think 2013, I think maybe when we started looking. And so at that stage when we looked for papers talking about CPR-induced consciousness, there was 9 papers. Yeah. So not many, not many at all. And a few of those were case studies. There was only a couple of reports where they'd actually spoken about any form of research, but obviously it's very limited. I think one of the case studies, though, from memory, spoke of a case that went for 2 hours and 40 minutes from memory of doing CPR with a patient waking up. So clearly we were blown away by this, the results that we actually got from it. So, and from there we blossomed again, and you went on and decided we'll do another research paper, which was the Spark of Life conference that was held in Melbourne.
Yeah, that's right.
And we did a survey.
That was very interesting.
Doctors, nurses and paramedics that attended and what their experience was with CPRIC. What did you find with that?
Yeah, because there was such a gap in between what was known in the literature and what people were reporting anecdotally. Like, as you said, we could only find 9 or 10 case reports across the literature of people displaying signs of life during CPR. Yet, when we surveyed people, have you ever seen this? Overwhelmingly, people had encountered it at least once, and many sort of experienced clinicians with 10 plus years of experience had seen it quite often. And I think another interesting sort of part of that study, we set ourselves up for this, of course, where we asked, like, do you know how to manage it, or would you like a guideline or something? And overwhelmingly, again, I think everyone said, we need some guidance here. What to do? What do you do? And
Evolved.
We'll talk about management in a second. But another interesting thing we did when it comes to the incidence and how frequently CPRIC is, we did a case review of Ambulance Victoria cases to see what has happened to the incidence, and what did we find there?
Well, we found that it actually started off really slow. I think it was 0.7% initially of all the cardiac arrests that you're actually going to. And over time, I think it went to 1.3. So the start of the data that we looked at to the end of the data showed a significant increase. Yeah. And there's many things that have caused that increase. And we'll speak about those in a little bit more detail in a moment. I think speaking about that survey stuff that we did at the Spark of Life conference, one really interesting thing from that was that pre-hospital clinicians experienced it more than hospital clinicians. And which is surprising because there's a bit of theory out there that the sooner you get to it, the greater the chance of you encountering CPR-induced consciousness. But from a lot of the doctors that were at the conference, they were quite bewildered by the whole thought of these people waking up during the CPR, which is really interesting, really a great piece of information for our pre-hospital clinicians that you may be explaining something to a doctor that's not aware about this sort of phenomenon. So, and I hate saying that word.
Phenomenon, So we've established that it was rarely reported in the literature, but we've found anecdotally people encounter it, and then we see that there's an increase in the incidence over time as well. But like if it's about 1%, we certainly have guidelines for things we encounter less than 1% of the time.
Yeah, when you say 1%, that's 1 in every 100 cardiac arrests that go off that somebody's going to actually experience it. So that's actually quite a large number.
Yeah. Yeah, and that 1%, initially that might be the sort of CPR-induced consciousness that's interfering with CPR. So we broke it down. We say, there's so many signs of life. Is it CPRIC that's non-interfering, meaning, a bit of eye flickering, twitches, movement, this sort of stuff, but it doesn't really impede on any resuscitation efforts. But then the more troublesome case would be the sort of really interfering types. And I think in early days, a decade ago, that was the sort of stuff that made it into the case report.
Yes.
Just say, patient was pulling out the tube, pushing the rescuer away, calling out. When we did that systematic review, one of the case reports sort of described the patient talking, saying, "No, please stop compressions, you're hurting me." And I don't know, I think they took that as a valid consent and sort of paused the effort. But in any case, raised an interesting point of the whole difference, the spectrum of CPRIC, I guess.
Speak about recognition now. So how do you actually recognise when somebody's got CPR-induced consciousness? That's a really important thing to think of, because, and I think what we need to speak about is the first responder. So you are Joe Bloggs walking down the street and you come across somebody who appears to be in cardiac arrest. And no breathing or agonal breathing, no palpable pulse, although we're not checking for them as first responders. So not responding, you start CPR and you've been going for 2 or 3 minutes, and all of a sudden the patient opens their eyes and starts looking at you. Your immediate response is what? You got to stop.
You got to stop, of course.
So it makes it difficult, but then you stop doing your compressions and this person then becomes unresponsive again. The eyes close again and nothing else happens. So you do your checks again and you start CPR again, and the same thing happens after a short period of time. So very confusing for the first responder. You've got the dispatchers on the telephone going, continue CPR, continue doing compressions, and yet it seems like you're causing trauma on this patient who's lying on the floor. You're doing compressions and they start opening your eyes. So it goes against the grain about what we should be doing as first responders. So it becomes very difficult for that first responder. As a pre-hospital clinician that turns up with a monitor, this gives us a bit more evidence to be able to back up what's actually going on.
If they're in a non-perfusing rhythm and you're doing good compressions and they're sort of eyes open, you can be more confident that this is CPRIC rather than the patient actually sort of not being in arrest. Because with social media, there's so many cases out there, videos of people doing CPR on patients who are asleep and certainly don't need CPR, and that causes a bit of stuff. But there's some good videos out there of CPRIC as well, and I think until you have that monitor and know what the underlying rhythm is, if you start compressing and they wake up, you have to pull back, don't you?
Well, you have to,
But just being aware of it, if they then lapse straight back into arrest with agonal breaths and they look dead, for the lack of a better term, back on the chest, and pre-hospital sort of first responders are probably more likely to encounter this if you witness the arrests, the downtime's been very short, there's still a fair bit of oxygenated blood around, so a few pumps of the chest hopefully gets that blood to the head and a bit of cerebral perfusion, and there's really no reason they shouldn't wake up.
And so I think a great word you said there, which is why we're doing all of this in the first place, is awareness. Because previously people didn't know about this. So if we can get the word out there and speak about it at conferences and so forth and produce papers, which you've already done, then it increases the knowledge. And you only need to look, like I said, 2015, there were probably 9 papers. If you Googled now and got on the internet and actually did a search for CPR-induced consciousness or consciousness during CPR or whatever term that you actually want to do, you would find there'd be over 100 papers now, easily. It has definitely become an interesting topic. A lot more people are talking about it, which is what we wanted to do. And so if you're a first responder, you may have heard of this before, and just like you said, if the patient starts waking up with CPR, then you'll go, hang on, Could this be CPRIC?
Yeah, exactly.
Which is really, really important. Good. So tell me about the incidence of CPR-induced consciousness. Like how often? We spoke about it briefly before.
Yeah.
So what, every
Yeah.
100 cases, you're going to see how many?
Yeah, there was sub 1% initially, probably a decade ago, but then with the introduction of high performance CPR, mechanical CPR, increased public awareness and shorter downtimes, all this sort of stuff contributes to a rise in the incidence, doesn't it? And what's the latest stats in AV? Probably at least 1.5% of cases would have CPRIC, if not more. We'll do an updated review of that.
Well, that's what it needs.
Surely.
It needs an updated review. Yeah.
So, when we talk about incidence, Matt, it's all well and good having a number and a percentage in the paper, but if you just think back to the last 10 arrests you've attended, is any of them
No. So the last 10
CPRIC?
cardiac arrests that I've been to, I've not experienced CPRIC.
20?
20, no. Well, you've got to take into fact that I've been working on the helicopter. So when I do cardiac arrest, it's often traumatic cardiac arrests. And by the time that we've arrived to them, they've often at the end of their resuscitation, because obviously they've had their initial management. I think if you did a snapshot of local road-based micro-paramedics responding to medical cardiac arrest, I think you would find the incidence of it occurring far greater than what you will in traumatic causes. Which is interesting because you could have a discussion about medical versus traumatic cases and look at the incidence of, well, there's your next research paper, look at the incidence of CPR-induced consciousness in trauma or in medical, and I think you will find that medical will far outweigh the trauma, plus also the numbers. So that's interesting, and I guess the thing to remember is that your exposure to this may be minimal. It's 1 in 100, but does that mean that you're going to be on shift or on duty when that 1 in 100 goes off? So by the time you actually get to see it, you're really low in numbers of actually being able to do it. And you look at a paper, I think Kylie Dyson from AV produced a paper a long time ago talking about within Ambulance Victoria, the incidence of advanced life support response paramedics attending to cardiac arrest, and the average worked out to be around 1 to 2%, of the 1 to 2 cases per year. So really, really small. And so then you throw in the 1 to 2 cases per year, and CPR-induced consciousness happening in 1 to 2 in every 100. Your exposure to it's going to be small.
Yeah, true. The concerning thing with Kylie's research there was, of course, that the patient survival drastically increased if the crew that attended had been to an arrest in the last little while. What does that mean for training and...
Well, we all get rusty, don't we? If you don't do things. I mean, you have a bit of background knowledge about what to do, but unless you practice, then your performance is not going to be as good. Yeah,
true. How should we manage this?
Yeah, $1 million question.
$1
million
the
question.
patient's there, compression's happening, tubes are being pulled out, fireys are being pushed away, words are being spoken, get off my chest.
How do you
manage that confronting situation?
That is definitely happened. I guess like we've spoken about already, recognition is the biggest thing. So you've got to be able to recognise. So on the monitor we've either got VFVT, asystole, probably unlikely to happen with that, and question whether you should be doing CPR on that person anyway. So VFVT or PEA with no obvious pulse or non-perfusing rhythm of some sort. So confirmation, we've got that. Patients now are opening their eyes and looking at us or moving. And we've spoken about the two types, the interfering and the non-interfering. So if the patient's non-interfering, my initial management for them is speak to them. Get down into the ear, tell them exactly what's going on. Hey, John, listen, you're in cardiac arrest, your heart's not working properly, we're trying to help get your heart back, just try and relax, close your eyes, try and relax, get yourself comfortable as best as you can. Clearly I'm jumping up and down on your chest, it's not going to be comfortable. But communicate with the patient, speak to them and inform them of what's going on. It'd be terrifying to be in that position. Imagine that lying on the floor in cardiac arrest, but your brain's getting perfused enough by really good compressions that you're doing, and then you don't know what's going on. You can't respond, you can't do anything, you can't reach up, you can't stop them, but your eyes are open, you're tracking what's going on. And to me, that person's thinking about what's actually happening. We communicate, and communication is probably one of the best forms of management that we can actually have. Then there's the interfering patient. And I've certainly read some case studies or clinical reports written by some of our paramedics on the road that have reported about patients physically trying to grab the tube and pull it out of the mouth, or literally clawing themselves along the floor trying to get away from the rescuers. And you speak to a lot of people about this, and certainly higher up clinicians, and they go, it's rubbish, the patient wasn't in cardiac arrest. But there's confirmation that there's VFVT on the monitor, CPR in progress, and the patient's physically moving away. So what do we do about it? Again, communicate. Talk to the patient, say nice words, speak nicely to them, have a think about what you're going to say before you rush in there and go, hey, you're dead and we're trying to keep you going. Probably think of something a little bit better than that. And then we move on to medications. And what sort of medications can we give them, Alex? You know, we've got a plethora of stuff in our bag, but there's a few medications that we looked at and we proposed being the best options.
Yeah. So to go about sort of answering that question in a scientific sort of evidence-based way, we did an international Delphi study, which just sort of means, I guess, a round table of experts. It was all over Zoom, but we got people from the States, Europe, Australia, obviously, and Canada, I think. We got a team together of specialists that had keen interested in this and had encountered it. And then we asked a much larger group, all clinicians, and said, how would you manage? Does it need management? CPR interfering versus non-interfering? And then through sort of 3 steps, we narrowed it down. This sounds awfully laborious, doesn't it? 3 steps just to get to the obvious answer, which of course is
shoot me already.
Ketamine.
Yeah. Ketamine for everything.
We knew that from before we started. Now look, you bring up a good point before that, you know, the patient is going to be uncomfortable. So intuitively people can understand a bit of analgesia, and if you don't have ketamine or access to such, even just fentanyl for analgesia and midazolam to sedate them. So that would be the sort of current guidelines for ALS paramedics in Victoria and probably other places where first responder paramedics don't have ketamine. So 50 mics of fentanyl, 1 to 2 milligram of midas, will that do it?
Well, potentially. And I think, you know, the important thing is whatever your service provider offers you, you know, work within your guidelines. Don't just sit here and say, Alex and Matt said, we can go ahead and give this. You need to work within your guidelines of your operation that you work for. And so if your company has a guideline already, fantastic, that's perfect, that's what we wanted. But if they don't have a guideline, then I want you to be speaking up and speaking to the people who produce the guidelines and say, hey, how about we generate something for CPR-induced consciousness? And then there are lots of ambulance services that have their guidelines available online that have clear evidence behind the CPR-induced consciousness and what they use. You can use that as evidence to take to your bosses and say, let's get a guideline generated. So a recommendation, you know, we started small because we didn't know how patients would respond. So we did go small doses, like 25 mics of fentanyl initially and 1 or 2 milligrams of midas, but it didn't work. And then ketamine at the same time, we said, well, let's just give 10 to 20 milligrams because that was similar to what we gave for analgesia, for traumatic injuries and so forth. But that didn't work as well. So we've moved on from that. So we've tried some smaller doses. It doesn't work. When the brain's getting perfused, obviously they need reasonable amounts of analgesia or sedation. And so nowadays, currently, we're looking at 50 to 100 milligrams of ketamine IV. The idea is that we don't want to keep on giving incremental doses. We want to stop it so that we can give good quality CPR from the start and continuing. Because you don't want to be going, oh, small incremental dose, oh, patient's interfering, so we interrupt our CPR again and we've got to go back and give another dose and, you know, wait for that to work. So let's hit them well and then actually continue on with the compressions and so forth. So we don't get those interruptions. There is lots of concerns about, well, what drug should you give? How much should you give it? We don't know. Nobody's done the research on how much sedation that you need to give during a cardiac arrest to manage CPR-induced consciousness. How much fentanyl and midas will have an impact on the patient's blood pressure because of the vasodilatory effects? We don't know. But what we do know is that we need to do something to be able to manage these patients because it is affecting the quality of their CPR.
Yeah, you got to protect the patients from themselves sometimes, don't you?
So Alex, tell me, what's good about ketamine with regards to a medication? You know, we know fentanyl and midas have got some bad side effects. What makes ketamine so great?
I don't think there's a single thing ketamine doesn't work for. They've tested it for virtually anything. it's all about the dose, you know. There's an analgesic dose and a sedation dose, and there's a party dose in between that we discourage. But
we're not talking about that on here, I tell you now.
But we might respond to some of those. But ketamine, so the benefits would be boost your heart rate, can bring up the blood pressure, as opposed to dilating the vessels and dropping the blood pressure. Opens the airways, which, you know, if the arrest is due to any sort of airway narrowing or asthma, that'd be an added benefit. It maintains people's own airway
and respiratory rate.
Yeah.
So I think that's probably one of the good things to talk about is we know that ketamine has less of effect on people's respiratory rate. However, if ketamine is given really quickly, it can cause apnea as well. However, at this point, we are ventilating for the patient during cardiac arrest. We're assuming that if we give ketamine and the patient does get ROSC, that the ketamine doses should not affect their respiratory pattern when they wake up. Remembering that post-cardiac arrest, most people will have irregular respirations and it won't always be fantastic to start off straight away. The thing that you spoke about there with the blood pressure is really good. And so there's been a bit of to and fro about ketamine not being a great drug in patients who are severely hypotensive. Yeah. You know, there's got a negative inotropic effect with it. In cardiac arrest, you know, we've got no evidence around this. Yeah. We can't back it up with any evidence at the moment. But what we're looking at is a drug which is providing sedation and analgesia for the patient. And ketamine, with all of those factors, weighed up to be the best one. We're hoping that if there are any negative effects or inotropic effects with the dose of ketamine, that the ketamine, beg your pardon, the adrenaline that we're giving will have a positive outcome, which will be overweighing the effects of the ketamine. But we don't know. No. There needs to be more research done on this, and hopefully somebody out there is keen on doing a research paper in the future on it.
We've got someone penciled in.
Oh, we have, Jack Howard. He's,
that'll be exciting.
He's doing his PhD on this very topic at the moment, so good on him. Well
Watch
done.
This space. What's your thought on ketamine potentially increasing ICP? We know that's a potential side effect. Does that have any implications in cardiac arrest and CPRIC? I guess if the whole point of CPR is to get some cerebral perfusion, increasing the ICP, is that a theoretical risk?
Well, it's once again, it's an unknown factor at the moment because it's a patient in cardiac arrest. And I think if you talk about ketamine and increasing ICP, it's a patient with borderline hypertension to start off with, or a higher blood pressure, and you give them the ketamine and it makes them go even higher. Yeah. So I guess that's the concern. In a patient who's got very low, borderline inadequate perfusion at this stage, if you give ketamine, is it going to raise their ICP through the roof so much that it's going to cause damage? I wouldn't think so. But I don't know. There's no evidence out there to say one way or the other. Now, I'm going to throw you into a scenario here. Yeah. You're doing your management. Yeah. You've got a patient who's waking up. You're doing CPR. You're giving your dose of ketamine. And the ALS crew perhaps have given some fentanyl, midazolam, I'm not quite sure. Anyway, patients now starts vomiting, but it's still got a bit of trismus. Oh. And you want to do some airway management. I'm making it really tough. You're doing compression of the eyes. Stuff coming out of his mouth. What can we do to manage the airway in these type of patients? Is there another drug that we can throw into the mix here?
Sucks.
Is that right?
I mean, mate, are we gonna? This is
that's going to go on the t-shirt next week.
Yeah, right. Buy shirts. Rocks. Intra-arrest sort of paralysis. That's interesting. I would give some rock.
Why not?
Yeah.
Why not? So I think 100%, let's be so clear on this. Yeah. Do not give rock unless you're given sedation. Yeah. Yep. So we want the ketamine, the fentanyl, midazolam, whatever it is that you're using as sedation, that needs to go on first. Yeah. If you've given 2 doses of it or 1 or 2 doses and it's still been ineffective and you've given adequate doses and you are unable to manage that person's airway, they're getting vomitus in it, they've got trismus, you can't secure it, it's potential to have aspiration and all the rest of it, then rocuronium brought in at that point is probably a very, very good option. Yeah. Dosage, as per normal, what you would do for an RSI. So 1 milligram per kilo would be a perfect dose to actually go with. Yeah. Easy. Bring rock in. Suction.
Copious of suction.
Yeah, absolutely. Yeah. We can talk about that in another podcast about suction with regards to airway management and so forth. I think there's a great lesson in that for any person that's putting laryngoscope into people's mouths. So, yeah.
Good.
Good.
Anything else you want to bring up about CPRIC? So I guess one question I would have, or even as a layperson, if they're waking up, does this mean that they've got a better chance of survival and sort of functional neurological outcomes?
Yeah, we'd like to think so.
Yeah.
We'd like to think so. Initially, when we first did the research, I don't think it actually proved any benefit at all, and no improvement in survival. No. It doesn't sit well with me. I think this is something that still needs to have further research done on it, because as we've sort of spoken about, with our faster response that we get to patients nowadays and the high quality CPR, the chances of that brain being perfused are going to be increased. Yeah. So if we're doing all of that and we're improving it, then the chances of survival potentially are going to be better. And once again, we need to do another paper looking at it. So it's been a while since we did our initial study. Jack's obviously going on and doing some research about it at the moment, and we need to push on and get another paper out. Yeah. Assisting Jack in any way we can about has it improved and what are the chances of it actually improving survival. A thing we didn't speak about before as well is the Good Sam. Good Sam is an international a app which basically will get to people to cardiac arrest sooner, and it's it ties in with that first responder thing. Is that first responders are going to be getting there much quicker. I've had the Good Sam go off at my house to literally addresses which are 400 metres from home. So all of a sudden you're arriving at somebody's house 2 minutes after the person's gone into cardiac arrest, or maybe a little bit longer because it take a bit longer to get dressed. But our response times are reducing, which is really good. So who knows? Who knows where this will go? Are we going to have an improved survival? Let's do some research and find out. That's how it starts, isn't it?
Yeah, exactly.
It starts with a question.
Another question I would have, I guess, is if patients displaying signs of life or CPRIC, should we continue resuscitation efforts beyond the traditional cutoff? So let's say there's no CPRIC, you're doing CPR, how long do you keep going for? They're old, they're comorbid, they're sick, you're pumping on the chest. How long would you go for? When do you call it and say, do you have to go for 30 minutes? Probably not.
Depends on which company you work for. It depends on your service provider and what their recommendations are. And every service will have a different recommendation. So in general, shockable rhythms and so forth, then you're probably looking at 45 minutes, thereabouts. If you're in a PA, you're probably looking about 30 minutes. Other factors for me are, like you've mentioned, age, pre-existing comorbidities, time for downtime, functional status within the community and all that sort of stuff. And when I say functional status, are they stuck in a bed all day, or are they ambulant and moving around in the community? Those sort of things. And then the other numerical stuff that I look at during a cardiac arrest is what sort of end-tidal CO2 are we getting? Are we getting good end-tidal CO2 throughout it? Have we had any episodes of ROSC and then gone back into arrest again and ROSC and into arrest? Because that sort of almost resets the clock a little bit. But you can't do it forever. There was that paper that showed that 240 minutes of CPR was going on for a patient, and you look at the trauma that's associated with that. There has to be an end point at some point. It can be a big, hard decision to make. Some people may go, well, we're doing CPR, we've been going for 45 minutes, there's a hospital 10 minutes down the road, we've got signs of well-perfused brain and good end-tidal CO2, then should we be loading this person with the use of a mechanical CPR device onto a stretcher and transporting to a facility with ECMO? That's another research paper in itself. If you have signs of life during cardiac arrest, should we be transporting to an ECMO facility to pop that patient on the ECMO? If the brain's still perfusing and doing well, that's what we're after. We're wanting to save people's brains and save their bodies and all the rest of it. $1 million question, mate. I don't have the answers to it. That's my thoughts and suggestions, but there's some more research out there to be done. We keep on talking about research a lot.
We'll do a separate podcast series on research methods. Could I tempt you with that?
I'll be dead silent in that lecture. You can do all of the talking there. I'll throw the questions at you, mate, because you're all over it.
But now, look, I like that answer. So you're taking many factors into consideration: age, comorbidity, functional status, downtime, etc. And CPRIC would just be one other factor in that.
Exactly.
It doesn't mean that you must continue.
No.
And it doesn't guarantee a good outcome. And if they've got all the other factors weighing against them, but there's a little bit of CPRIC, some non-interfering, or you probably wouldn't be compelled to carry on. But every case on merits. And,
Wonderful. Yeah, I think that's the important thing. We can't say you must.
Yeah.
I think you need to weigh up everything that's going on around you at the time, and you need to make a decision one way or the other. And that is speaking to the family, speaking to your colleagues, even engaging with another hospital service or the receiving hospital and say, this is what we've got. Yeah. You know, engage somebody else. Don't always have the idea that you have to take on those big decisions by yourself. The use of consulting, consulting with another clinician, and not just within your group, within an external group, to just put it out there and say, do you have any other thoughts or suggestions? It's a very mature, responsible way of approaching the job. I think that's really important. And they may have another idea and they may have some clarity about it. Just go, you've been going for a long time. I know you've got some signs of life with the CPR-induced consciousness, but blah, 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 blah means stop. Yeah. So,
beautiful.
Good.
Anything else?
No, I think we've done CPRIC to death, but we are always open to answer questions about it if anybody has any questions about it or wants to know further. We do have obviously some research out there about it, so if you just Google our names, you'll come up and find quite a few. If you Google CPR-induced consciousness, there'll be a plethora of information out there now. As I'm sure you've all seen on the socials, if you type in CPRIC, you'll have lots of videos that come up. One good video that came up recently, I think, was from New South Wales Ambulance, which during their paramedic show that they do up there, highlighted a good case of CPR-induced consciousness. As you've mentioned previously, there are some shit cases and there's some really good cases of it. But pick and choose, but being exposed to them, having an awareness, spreading the word is what we're after. And I think we've done that quite well so far.
Tag us in any videos that you see, and we will give our 2 cents worth.
Well, what we
because
could
it's
do
hard
is
to know without all the info, but
create a file on the web page of CPR-induced videos. There you go. There's more work for you.
Oh, beautiful.
Yeah. So you could click on
all the online shots of potentially CPRIC, and we'll branch them. This is definitely CPRIC.
Yes.
Because we've got the monitor we see, and then potentially not.
I've got videos in mind already for the potentially nots. So that's good. That's very exciting.
Good.
Well, I think that's good, mate.
Yeah.
I think from that, like I said, if anybody's got any questions, get in touch.
Yeah.
I think that's probably the most important thing. And we'll
good.
go from there.
Like, subscribe, share.
Get in touch.
And thanks.
Thank you very much.
Bye.
Cheers. Bye.